My name is Michael Fish. I'm the editor of the Journal of Supportive Oncology, and I'm here with Donald Abrams from UCSF and Richard Santon from the University of Virginia and Deborah Barton from the Mayo Clinic. And we're having our post-discussion after day 2 of our Chicago Supportive Oncology Conference. So maybe the real issue is it's not so much that we have to understand placebos per se, although that's super interesting, but we want to understand what works and what doesn't work. And we talked about how there's just too many negative trials. And it may be that placebos will provide some sort of clues to the unexplained variation that sort of creates noise where we can't understand the benefits of interventions and whether or not they're truly there.
I mean, that's one way to look at it. I'm thinking if we had a blood test for who's going to respond to a placebo, and a woman has hot flashes, I'm going to measure your placebo response titers, and she's high, and I give her a placebo and she responds, that's looking at it in a totally different way. Now, we would need to know what about the mechanism of that, but if we could do that, we would then have an agent that would be quite effective without a lot of side effects.
Right, but it depends whether what she's responding to is unique to the placebo. It may be that there's some indicators of likelihood of response to an intervention. And if you could prove that, maybe you're proving it through placebo-related research. But if you knew that, you might use that measure as a stratification factor for trials, and then you could get a better trial.
Was this the question of expectations that you brought up?
Yeah, I think one of the things to look at is expectations in terms of beliefs and attitudes towards an intervention and how much you think it's going to help. But also in health psychology, there is a whole literature on placebo and placebo response and what that means and who can have a placebo response. And I was struck by, I think it gets back to the plasticity of the brain, and I was struck by some literature in the Parkinson world about giving dopaminergic agents over a period of time and then substituting a placebo and looking at brain imaging to show the exact same response dopaminergically to the placebo as has been given with the drug.
We just did a study of 250 chronic pain patients, and we did an integrative medicine clinic intervention, not otherwise specified. So they got at 9 different centers, either acupuncture, nutrition, chiropractic, yoga, whatever. We didn't specify, whatever it was. And we saw a significant improvement not only in chronic pain and impairment from pain, but also in depression, stress, and quality of life. And we did ask before each visit what your expectation was for relief of pain at this visit. And so what we're going to do now is analyze this data looking at expectation to see if that is the main predictor of outcome.
Great.
So the great thing about the Chicago Supportive Oncology meeting, I think, is having investigators from different disciplines, hematology, oncology for you and I, palliative care, endocrinology, nursing, and symptom research, from different parts of the country, talking about a different set of topics and trying to understand the symptom science and the common themes and finding some common ground. It's been a very exciting meeting.